podcast for those who suffer, which is everyone.
It's a space where we can speak honestly about what it feels like to be in desolate places without losing hope.
Welcome to In the Thicket. Hey everybody, hello.
Hello.
Hey,
How's it going?
Yay, good. Welcome to this episode. I'm so excited because I get to see your face, Dave. It's so nice.
Yeah, it's my pleasure, and I really enjoy seeing you again, of course, and so happy to be here with you all.
Yeah, it's great.
Yeah.
It's great to have you. How are you ladies doing this week?
good.
Too
It's
bad.
lots of snow
Yep.
since the last time we recorded. So,
Mhm.
and we're squarely in Lent, so that's great.
Mhm.
Yeah, it's
it's-
going all right so far, Lent.
If I had to ask you this question, okay, let me ask you this because this is definitely something that is pertinent for Dave, for Dr. David D'Souza. If you had to choose a kind of beer, what would you say if you had to drink one beer for the rest of your life? Obviously not all the time, but like one kind, what would you choose?
That's funny, that only you would ask me that question. But you know that I like beer a lot. The answer is very easy for me. It's called the West Veteran 12. Okay?
Yeah.
And the reason being, it's a very rare beer. But the reason being is that it is it's considered one of the best in the world, and it is made in Belgium by Cistercian monks. And it's been by the same community for hundreds of years.
That's cool.
And the history behind it is so unique, and it's so beautiful. And I love how the Cistercian monks use that for the glory of God. They use that work to bring people to God. And people travel all over the world to come to their monastery. And recently, people offered them millions of dollars to expand their beer making process.
Yeah.
And they said no. And the reason why is they want people to come to the monastery, right? They want people to experience God in their monastery, and then have the beer from there. And then they could take the limit amount you can take home, but I just love how for them it's all about bringing people to God through their work, and just
so
that
great.
history, it just makes it even more special.
That's awesome.
So that means one day I'm gonna have to go there and actually get one of those.
Exactly.
One of those
I'll come with you, man. I had one at
I'm taking you with me here.
Yeah, totally. I had one at there's a pub across from St. Patrick's in Toronto on McCall Street called Sin and Redemption. And I went there by myself for supper one night, and they had some West Veteran, and I had one, and it's like $33 for a little.
Oh, wow.
Like that. It's like,
Because someone went to the monastery to get that little bottle.
Right. Exactly.
Exactly. And it was good. Yeah. So that I would probably pick that one too, or a really nice oatmeal stout. How about you, Rachel? If you had to pick one, what would you pick?
I feel like, well, now how can I don't know. It sounds like the beer to pick. What else am I going to pick?
Yeah, you're anti-Catholic.
We're gonna have to go on a group
beer.
visit there. We're gonna have to take a group trip, right?
That's right. Yeah.
I'm really,
podcast pilgrimage.
That's right. Oh my gosh, that would be awesome.
That would be
what a
awesome.
cool thing. I'm definitely gonna look this up after our episode. Yeah, no, that sounds really good. But probably I don't know. I'm really boring. Probably something like a Stella or a Heineken or something like along those lines. You know?
Nicole, how about you?
Yeah, I mean, okay, it's hard. I feel like my beer tastes, they just change. So for a while I was like amber beers only, ever, always.
Oh.
But then there's one, I think it's an IPA. It's from Collective Arts called Hazy State, and it's like an unfiltered IPA. I think it's an IPA. I could be wrong. Anyways, but it's really good, and I've been enjoying that one lately too. So I don't know.
There's a beer. Oh my gosh, I don't know Toronto well at all, but it's anyways somewhere in Toronto, somewhere very. If I mentioned, everyone would know exactly what I'm talking about, but I don't know what it's called because I can't remember. But we ordered this beer called, I think it was an in-house or just a local beer. I don't remember how local it was, but it's called Hopped and Confused.
Oh, yeah.
Really good. Like, it's very hoppy, obviously, but it's like it was very good. So I remember that being kind of different than what I normally drink, but I really enjoyed it. I don't know if I drink it for the rest of my life though.
Okay.
Yeah,
yes.
right.
Yeah. See, West Veteran all the way.
Yeah. Well, I'm so impressed with Ontario too. Like, I think in the past 5 to 10 years, Ontario's breweries have really exploded, and they have some really, really great local brews here, and yeah, it's wonderful.
Totally.
That is
I
fun.
really hope
But it's
that
unfortunate we can't go to bars these days.
Yeah.
I know, yeah.
I know.
Soon, hopefully.
We could do a
Right.
virtual taste testing.
That's right. Well, you and
Yeah.
Nicole, actually, I can. I can go.
Right. Yeah, we're
Except
still
that it's
in.
Lent. Usually I don't drink
Yeah.
alcohol during Lent, so I'll suffer with you and in the time. Oh my goodness. Okay, so on to the topic of the day. Just
From beer to
from beer to euthanasia. Okay,
Right.
that's but today is the second in a series that we're doing for Lent. So we wanted to talk about euthanasia, and if you want to listen to kind of the whys behind for why each of us felt like it was important to do this series, you can go back a week and listen to our previous episode, and that will give a lot more context. But in general, there's some legislation that's before Parliament right now. So they're kind of debating this bill on expanding euthanasia and striking down some quote unquote barriers to euthanasia. So we felt like it would be an important time to really hear from some different voices who are kind of in the mix of things. And one of those voices that definitely came to mind was yours, Dave. So you are a medical doctor, and I'll let you maybe just start by telling us a little bit about yourself, like where you are, what you do, kind of, and especially in terms of like palliative care, caring for those who are, nearing death or are older or whatever, like what that's been like for you, and maybe why that was kind of an area of medicine that you wanted to get into.
Sure. Yeah. Well, thanks again for having me on the show. That's really nice that you thought of me. I certainly, I mean, I'm really happy to accept the invitation. But there's many wonderful voices out there, and that's nice that you thought of me. So, I've been a physician now for I think almost 10 years, and I graduated as a family doctor. But my kind of true passion is actually working with the underprivileged populations, particularly in developing countries. And I spent some time working in Africa and different places in the world, some slum areas, and did a fellowship in tropical diseases and global health, so I could hopefully focus a little bit more of my career on that. When I did a lot of my traveling and I came back home, I realized that, look, we have such a vulnerable population here in our own city of Toronto. And there's not much of HIV and TB, I mean, there is an HIV population, but certainly TB is something that I've been focusing on my time in Africa, but it's not a big problem here. I do teach on the subject at the university, so I keep that up to date. But I really wanted to focus on sort of the needs of our community here and the needs of the vulnerable people over here in Toronto. And so I really thought about working with the elderly. So, when I first started my practice in Toronto, I got into care of the elderly, working with nursing homes across the city and with palliative care. And I realized these are two areas that are in such high need. We know that there is very few physicians actually focus their practice in palliative care. We know that there is a high demand and need for palliative care services that's only growing and growing as the baby boomer generation is getting a little older.
Right.
And so, unfortunately, there's that wait list is getting longer and longer. And that's something that I, really hoping that we can address as a community. So right now I focus my practice on care of the elderly, palliative care, mainly in the GTA and in Scarborough. So if you know the Toronto area.
Yeah. And that's, I mean, I know that that's a passion of yours, of like supporting vulnerable populations, and like some of the medical kind of mission stuff that you've done before is really beautiful. And it's interesting to even name that that's a vulnerable population, because I think a lot of people might kind of miss that, or a lot of people might not realize how much of a lack of access there is to palliative care. So maybe what's been your experience of that, of kind of seeing what a huge challenge it is, like what a demand there is for it, and kind of the shortage of that.
It's a good question. In my time in Africa and in developing countries, I find that, the suffering that I'm seeing there is a very stark, it's a very visceral kind of suffering. People are suffering from a great deal of physical pain, could be advanced diseases. I've seen people with rheumatoid arthritis that is literally disabling their entire hands completely within a few short years. People with malnutrition who are dying, in the process of dying because of malnutrition. Malaria associated diseases. There's a very visceral physical suffering that we see in the third world, or the developing countries, shall I say. In Toronto or in Canada, I find it's very different. We obviously have a relatively a good healthcare system in comparison to many of these other countries, and so a lot of those kind of advanced extreme diseases we don't see. However, what I find in my practice, and especially with care of the elderly, and definitely within the palliative care and my palliative practice, is there's a great deal of suffering, but it's a little bit different. Certainly there's that physical sense, but there is also a lot of psychological suffering, and a lot of mental health suffering, and a lot of loneliness. And this goes into the reasons why a lot of people think that think that euthanasia is a way out of that suffering. A lot of people are thinking about euthanasia because they feel very lonely. They feel that no one really cares about them anymore. People are thinking that they feel abandoned. There's a sense of a loss of function in today's world. Maybe they used to be a high functioning engineer or a doctor, and now they can't do that anymore. There's a sense of a loss of ability. And it also, that all comes down to a sense of loss of community, a sense of loss of identity, and a sense of loss of dignity. And these are all the reasons that I'm seeing in our community here that lead people to think that euthanasia is a way out.
Yeah. I'm reminded of, so I'm a neurologic music therapist, as by trade, I guess. And I remember that a client I had years ago, and I'll change, and I'm sure if we talk about cases, we were talking about this earlier, we'll change any identifying information so that we're protecting confidentiality here. But working with somebody who was kind of had a lot of chronic pain and mental health issues, and was in kind of long-term care. And this person just didn't get out of bed. And the goal, what we were trying to help work on was, using music to help motivate and to get the person out of, get the person kind of alert and awake, and then get them walking and so on. And it was very inconsistent whether we were successful or not. But then I started noticing a pattern that the days that this patient would actually get out of bed and walk were days that days that would be like the day after a family member had come to visit. And pretty much that was the only thing that would make this person have that will to kind of to try to keep living and try to keep getting out of bed was having a visit. And it started to kind of clue me in, I think, kind of what you're saying, Dave, that there's this sense of loneliness. And I think that we get our sense of value. I know that I'm valued as a human person because other people love me and care about me, and they show this through their presence. But if no one is showing me that through their presence, and they're not with me, I start to think that I'm not valued, I'm not worth living. And then once you think that you're not worth living and that you're just a burden, then that's tough, So yeah, and it is, I think, having worked a little bit in, with older adults, it's just really, it's really sad. The loneliness is kind of everywhere, so yeah.
Yeah, we all get that sense of loneliness here and there in our lives, but I think when we're a little older, sometimes that experience can be a lot more difficult to deal with for many reasons. But when you're in a nursing home, and particularly during this time in COVID, right,
Yeah,
where even family visitors are not even allowed to visit you, family and friends aren't allowed to visit you, that kind of sense of loneliness has been exacerbated, and that has been going on now for a year. I've really seen that, and and mental health really has been affected significantly across, at least in my practice, I've seen that. But it really goes to show that that sense of community is so very, very important for everyone, especially our elderly. And they need to know that we affirm them, right? They need to know that we love them, that, you know, that they're worth something. They have that full dignity that they had, you know, even before they were, you know, before they were sick. Maybe now they're having some dementia, their memory loss. Maybe they have some difficulty with their bowels. They might need a diaper. They might need assistance for their basic daily habits. And a lot of people feel ashamed from that. And we need to let them know that they shouldn't, and that we love them just the same, and they're valuable, and they're dignified, not simply because they can't do those things anymore, but because of who they are.
Yeah.
I worked in law for a little while, and I remember working with someone who, they said to me, like, they were fairly young, they were still in their 30s, I think, and they said to a group of us, like, man, the worst thing for me like that could ever happen is just to lose my capacity to function physically. And basically they were talking about getting old. They were like, you know, that's like the worst thing ever. Like, I'd rather die. And I remember thinking, like, whoa, that is really, like, that is, but I mean, you know, and as I've gotten older and matured a little bit, I'm like, okay, yeah, I understand why people feel like that, because there's such a sense of, I think especially in North America, like, we put so much of our value on our capacity to do things and to contribute and to be independent even, right? And there's not, there's so much value that we put in that when we lose it, it's like, it is a loss of identity almost. And you have to sort of, you know, which is where for us as Catholics, our faith can come in, because our identity, we know, is supposed to be in the fact that we are children of God, and that is everybody, you know.
And even in the presence of somebody who's like, I think there's an element of the Catholic faith that we need to kind of reclaim and realize, which is the fact that the presence of somebody who is suffering actually is a gift in itself, because it draws out of other people their own vocation to love. Like, if I'm in the presence of somebody who's suffering, my response of that it needs to be love, whatever that looks like. And that's actually like the fundamental meaning of who I am, is to like give myself in love, you know? So being able to like reorient and reframe how kind of we're looking at, but being like, even myself, I'm like, I can go to the washroom, I can do all of those things, but like with chronic illness, you know, like my dad cooks for me a lot of the time, you know, and even that is like hard. And there is a place in me that is so resistant to that, like, you know, so I can, like, I'm wondering, Dave, maybe if you have any stories of particular experiences of where, like, maybe where people are getting close to death, or just with that kind of loss of, you know, independence and things like that, where either it was really hard for them, or even where you saw people kind of embrace that, and what that looked like.
Sure, yeah, and of course, you know, a big component of that is pain. True pain can be very difficult to deal with, absolutely. And it's hard for other people to understand unless you're in that situation. And that's why it's so important that we have that as a society, as a community, we put the resources in to help train palliative care physicians and provide for palliative care physicians, allow family doctors to have the training, and encourage them to assist people in that process, right?
Can we, sorry, I know that that's a really good question that you asked, Aaron, but just for our listeners who maybe don't know exactly what palliative care entails, could we just define that real quick before we go into stories?
So right in a nutshell, palliative care means to care for a patient's, to treat their suffering, okay? And that could be physical, mental, spiritual, psychological, okay? So as a palliative care physician, I identify that entire, what that patient's suffering is all about, right? The physical dimension, the mental dimension, the emotional, and the spiritual dimension. And as a palliative physician, my job is to treat the patient and help alleviate that suffering. It is not to kill the patient as a means to end the suffering. It is to treat the suffering itself.
Right. Thanks. Yeah, that's a helpful
Yeah.
definition.
Yeah.
Yeah, because the idea then is somebody who is dying. So we're not looking at that to that point, at a cure or, trying to alleviate, sort of fix the illness, but we're not also trying to hasten death. So it's this middle zone of like, well, okay, what is the suffering, the particular suffering that this person is experiencing, and being able to treat that. Thanks. Yeah, that's very helpful, actually.
Well, in palliative care, there are many people who have chronic diseases, right, that have decreased life expectancy. It may not be 3 months or 1 month. It could be 5 years or longer. Right? But we know that they may have a life-limiting disease, and that we can intervene at this stage. Right? We don't have to wait 5 or 10 years on the road. Intervene this stage and work with them over that time. Right? Journey with them over that time, or 5 or 10 years, or whatever the time may be. And to work with them to treat that suffering that they may have, that physical, that emotional, all those other things I talked about. It is a journey with a lot of these patients, right? And we need to always reassess, and it's a dynamic process, right? Patient sufferings do change, of course, as the disease progresses, but also as their own lives change, right? As their function changes. Maybe maybe yesterday they were able to go to the washroom themselves. Maybe today they can't. And so it is a dynamic process, and something that as physicians we need to journey with people in that time. And a lot of people say, well, what's the life expectancy? Is it 1 month, 2 months? And we do have some indicators that we can use for that, rough indicators. And it's those indicators are more helpful, particularly for cancer diagnoses. But in many cases, we don't have great indicators, and honestly, only God knows. And so we need to journey with those patients in that dynamic process.
Yeah. I wonder if you might be able to describe for us a little bit about what a good death can be, because I think there's kind of a like, it's easy to look at death as just being like horrible and a whole path of suffering and pain and loss of control that eventually ends up in, in death, and like to see that process as being just hugely awful, which it can be. But I'm wondering if you might be able to, share a little bit about that.
Well, I think first and foremost, when you're talking about that, we have to realize that death is inevitable. We all will go through that process, right? And with that, there is going to be a component of suffering, absolutely, right? I think for a lot of people, when we're talking about the euthanasia agenda, we're looking at it as a way to escape suffering, right? Right. And so I think first and foremost, when I think of a good death, I think the person needs to understand that those two things are part and parcel of being a human being and the human condition, and that I'm not, when we're looking at a good death, I don't mean to say that someone may have a lot more suffering than another, and that one way is different, is a better death than the other. But I think the acceptance of that human condition is very, very important about understanding what a good death is. There's a patient I had. He passed away maybe 4 years ago, and he was on the wait list to see a palliative care doctor for over 2 months. He had chronic kidney disease. His kidneys were shutting down, and he was on dialysis for a number of years at that point. But he also had a leg amputation due to severe diabetes, and they had to amputate one leg, and the diabetes caused an infection, so I had to amputate that. He was in a wheelchair. He lived with his wife, and he had no other family in the area. And at that point, he was very, very depressed as well, and he decided not to continue on with his dialysis treatments. And so, when you stop going to dialysis, usually the death process, accelerates pretty quickly, because the kidneys are in his case, the kidneys were shut down. So I did see him after 2 months and on the wait list, and I saw him, and he was literally at death's door, and he was in severe, severe pain and a lot of mental suffering as well. And the first thing he said to me was, oh, you're the palliative care doctor, great. Can you provide MAiD for me?
Mhm.
Right. And that really, really struck me. I was really, I was very touched by that, because I saw in him a desperate need for comfort, a desperate need for someone to address, at least in this case, primarily his physical pain,
Mhm.
and certainly, of course, the emotional component. And I did tell him that I don't do that, but I did tell him that there's so many options he has for his pain management. And he was really surprised, because he said, well, I thought I I thought there was no one to help me with pain, and I thought my only option was uh, either I die at home with no one there, or I get MAiD. He
Mhm.
didn't know that palliative care is an option, and I think that's so important in this society where, you know, we lack palliative care services. We need to have, and people do have significant physical suffering for months, maybe even years, without access to those services. So in the discussion with MAiD, we always need to talk about palliative care and making sure that people have palliative care services. Now, in this particular case, for this gentleman, we did start a lot of pain medications. We started medications for his mental health. His symptoms were much, much better controlled. He he immediately withdrew his request for euthanasia when he realized that there are options for his pain, and that someone would accompany him during this time. And that's a big thing, because he thought he would have to die alone in his house, and that him and his wife would have no medical help. Right? And he thought this would be a very lonely process. And so I accompanied him during that time. It was about 2 or 3 months of him passing away at home, and he was comfortable, and he passed away in the end with his wife by his side.
Mm.
So, to me, that was, I would say that was a good death. Again, hard for me to put an exact definition of good death,
Yeah.
but I think, and just to be a little bit clear on that, his decision not to go on with dialysis is not the equivalent of euthanasia. Okay,
Mhm.
Right.
he decided not to continue on with that treatment, and he passed away by natural means. So that's
Mhm.
not euthanasia. But he was comfortable at the end.
Mhm.
And he did accept his situation, and accepted his suffering. But there is a community responsibility, okay, in a good death, right? We have a responsibility to to journey and to really work with people who are end of life, to not neglect them. We have a
Mhm.
responsibility. So I think, when we talk about good death, it is a responsibility from our point of view as well. We have to be there to assist our elderly as they go through this very, very challenging process
Yeah.
and this natural course.
Yeah.
So it's a two-way street. And I think if done well, it is a beautiful thing.
Mhm. Yeah.
Guiding that process, I'm just thinking the term that came to mind was this term we use in sort of evangelization, verbiage. Like anyone who's involved in ministry, we all as Catholics are called to evangelize, but anyone who's involved in direct ministry, we all have heard this term intentional accompaniment, and so it's this idea that exactly what you're saying, like in the spiritual life, you walk alongside someone as they grow in their journey of faith, because it's a process, it's a dynamic process, exactly like how you said. And I was just thinking, that's really what we're called to. That's what community is. Like, community isn't slapping sort of programs onto things, or it's not concepts, it's people coming alongside people, and that is what Aaron was talking about, because that requires sacrificial love. Like, that requires time, that requires listening and presence, and choosing to do an area of medicine like palliative care, where you are in service of others, or volunteering, whatever it might be. It requires people to make that sacrifice for others.
Yeah.
And that's a challenge I think the Lord is is highlighting for us as people of God, as people of faith, that there's a need here, and we have to assess what our capacity is to contribute to that need, you know, wherever we are in our lives.
Yeah.
Absolutely. And I think, you know, it's a good point. And I don't think we need to look far for that, right? I mean, I think all of us, you know, we can talk about, you know, sort of doing a lot of things that you're doing, which is amazing, doing these podcasts, which is amazing. A lot of people, though, you know, may not be doing podcasts, but there's ways they can help in their own circles, right? I'm sure they know they have you know, a sick grandmother or grandfather, maybe going to visit them or speaking with them, or, you know, maybe they have a sister or brother who have some sort of life-limiting disease, or going through a mental health issue, you know, accompanying them, you know, making sure that they know that they're loved and that you're open to you know, to you know, journeying with them. I think that can go a far you know, can go a far way to help with people suffering. Absolutely.
Yeah.
Totally.
Yeah. That's actually even just a good point to let people know that we have on our website, inthethicketpodcast.com. There's a section there of things that people can do or get involved in. So both on kind of the political end of things and, you know, signing petitions and stuff, but then also in terms of like community organizations that, you know, people can choose to get involved with, where they're visiting the elderly or, you know, the sick or things like that.
Absolutely.
So I'd encourage people to take a look at that and choose something, you know. To get involved in.
And one other point on that is something that we all can do is pray for people who are dying, you know. And one thing that has been near to my heart is the Divine Mercy chaplet. And you know, Jesus promised to Saint Faustina that those who pray for those people who are dying, who are passive, who are in the process of dying, those people will receive, the people who are dying will receive a special grace from the Lord. And I think, you know, with that kind of message and assurance from Jesus, you know, if we know someone who is dying, we really should pray for them and to pray that chaplet for them. I think it obviously will do so much for them, and they may not even know it.
Yeah. I mean, maybe I can swing us in a little bit of a different direction here, so we can make sure we hear from you on this, because I know this has also been near and dear to your heart, is looking at kind of the conscience rights of physicians and other healthcare professionals. So I'm wondering if like what that process has been like with having, you know, MAiD come into effect while you're, you know, going through your medical studies and becoming a physician, and how that's affected you, whether you've kind of felt pressured at any point or worried with respect to your career, or what that's been like.
And also as part of that, maybe because you highlighted that there's a distinction, for example, between refusing certain treatments because, you know, in the course of someone's treatment of a disease, and what MAiD, medical assistance in dying, what that actually is. So maybe to share, because I don't think we've actually described what that is for people and what's being expected of doctors to do in that process of MAiD.
Okay, let's talk about that first, you know, the distinction. You know, there's definitely a lot of confusion about what MAiD is in the society. You know, sometimes people will go into hospital, especially if you go in with an elderly, and the first thing they'll ask you is, or one of the first things they may ask you is, if your heart were to stop beating, would you like CPR? If you stop breathing, would you like intubation with a tube down your throat to help you breathe? Okay, and people are worried that if they say no to those things, no for CPR, no for intubation, for having a machine breathe for you, that means euthanasia. It does not. Okay, this is something that is a common misconception. You know, and oftentimes I for a lot of patients, I do not recommend CPR. Okay, you know, CPR is meant for people, in my opinion, to who have maybe an illness that may affect their heart, and if you resuscitate them through CPR, that they may recover quite significantly. Okay, that's kind of a general concept, right? But certainly, if you decide not to go through that, you know, and let the process, the illness continue and through its natural course, some people might pass away, but that is through a natural means. So I have patients, for example, who have who are in the later stage of their disease, maybe with cancer or severe heart conditions, who I think very recently decide not to have CPR, okay? Because the chance of CPR to be successful, number one, is very limited, very minimal. Number two, even if they were to be resuscitated, their life expectancy would still be very, very, very low, okay? And so saying no to CPR or some of those life extending interventions is not the same as euthanasia. In euthanasia, there is a direct intervention with the goal of ending that person's life. Okay, a direct means to end the person's life. Okay, with palliative care, I may give a medication in proportion to a person's pain and suffering. Okay, to treat the suffering. That's the intention. Okay, my intention would never be to kill the patient with that medication, and therefore the medication I would give would be at a dose that's proportional to their physical pain or their symptom. Okay. In euthanasia, I would maybe change the dose or give them other medications in combination in order to end that person's life. That it would be the goal in euthanasia. So there's the difference.
Right.
Okay. Okay. And refusing a life-prolonging intervention is not the same as euthanasia. Again, euthanasia is the direct intention to kill or take another human's life with the medication.
Right.
Yeah.
Okay.
Which now, as doctors, it falls on a doctor's shoulder to do or to carry out that intervention, which is where Aaron's question about pre the legalization of euthanasia and post the legalization of euthanasia, like how has practicing medicine, even training and all these things changed, and what are those kinds of pressures that doctors who have major moral disagreements and conscience disagreements with this, what are you guys facing right now?
Well, that's a great question, and things have been changing literally in this area by the month. Okay, when euthanasia was legalized several years ago, when the law was struck down, let me put it that way, that made it a criminal part of the criminal code to conduct euthanasia. I think that was in 2016, if I can remember correctly. At that point in time, at least the medical community was told that this would be for very, very small and very few cases, okay, and that most people would not qualify, and that there would be special assessments, and that doctors who disagreed with that would not have to be part of that in any way. Okay, so there was this kind of assurance from everyone, whether it's the political or the medical community, the leadership medical community, that that our conscience rights would be protected, that patients would be would also be protected from abuse of this, that very few people would even qualify. But just in a few years, we can clearly see that's not the case. Okay, and they're changing the law so quickly with this new bill C7, I believe. That process would make it even more accessible. So in this new bill, they're saying that they're going to remove the requirement for reasonably foreseeable death. Okay, initially, there was a requirement for them, but I've experienced many cases where patients did not have a reasonable foreseeable death, and yet were still access to euthanasia. So now they're just removing that requirement completely, because I think they knew already that it wasn't being taken seriously, honestly. And then there is a waiting period, a 10-day waiting period from request, okay, to actually going ahead with euthanasia procedure. Okay, and the reason they have this 10-day waiting period is, well, maybe the person's going to change their mind. I have always said that, first of all, 10 days doesn't even make sense. If someone has a severe depression, right? If you know anybody in your life who has anxiety, depression, people don't get over these things in 10 days. Right? It takes months, maybe years, and sometimes people have a chronic depression, right? So to even have a 10-day waiting period is I think ludicrous. 10 days is such a small, insufficient, really. But now they're going to remove that, okay, with the new Bill C7. And then the third thing that they're thinking of doing is allowing for people to pre-consent for it. So consent with advance directives.
Right.
And this would really affect things, especially in my nursing home where I have many patients with dementia. I do have multiple patients who their families have even requested euthanasia for them. But I've told them it's against the law. The patient cannot consent because they have significant dementia. They can't even understand what euthanasia is. But now if this law goes through, it will open the gateway for people to allow advance directives, have them say, I would like euthanasia if I were to get dementia, or I wouldn't be able to, and then at that point, they would, they would have to undergo euthanasia at that point. So this is all very, very concerning. And from a physician's point of view, I mean, this is a huge concern from my point of view in terms of medical care, obviously. But our conscience rights have not been enshrined. Okay, and this is very, very concerning as the law gets more and more progressive in this direction. So and that's something that in Bill C7, I think Garnett, you had on the show previously, right? He's been a really big proponent of conscience rights, making sure that doctors who object to this have their rights respected. But that has not been the case. We haven't been able to get the MPs to agree to that. And the College of Physicians and Surgeons of Ontario have actually been, have said and made it very clear that they expect physicians to, in the least, refer patient requesting euthanasia to another party who does not see euthanasia as immoral. Okay, so we have to make what we call an effective referral to another party who may be consenting to this procedure. Okay, so in my point of view, that is undermining my conscience rights, because I don't think it's in anybody's best interest, certainly not the patient's best interest, for me to refer them to someone else who thinks that euthanasia is moral, right?
Yeah.
But unfortunately, the College of Physicians has been clear on that. Now, there has been attempts from many of us conscientious objectors to ask the physician community, the College of Physicians, to change it so that at least there's maybe a self-referral process. A patient can self-refer themselves to if they really want to go ahead with that, okay, they can self-refer themselves to maybe a government euthanasia panel who can then come in and do another third-party assessment. But this has, up to this point, has been refused and they haven't gone ahead with that. And I think that would be a very, very an easy way to assist us and to protect our conscience rights, but they have not done that.
Yeah.
So I almost feel there's a little bit of a strong arming of physicians in this regard to push us towards either accepting this or maybe taking some consequences. And that's where I'm a little bit scared right now. And a lot of the physicians are scared in our community about the potential consequences of not following through with the euthanasia agenda without conscience protection laws in place.
Which is so, I mean, I can't even imagine having to have this conversation over these last number of years and continuing to be frustrated, just even in this one small request of like, can we hold on to our moral convictions as medical professionals, and especially as medical professionals who want to specifically work in this area, which is so frustrating because hearing your heart for people as a doctor, wanting to help them with palliative care when they're suffering, and then knowing that like this kind of requirement from your regulatory body is a deterrent for other people who have just exactly that passion, because your license will be on the line, and so it's like, it's so awful to know that good doctors who want to serve are being put in this impossible position.
Absolutely. And I think it's going to be devastating to the palliative care community.
Yeah.
The Canadian Palliative Care Society, the National Canadian Palliative Care Society, has made it very clear that MAiD should not be included under the palliative care definition within the scope of palliative care. They've made it very clear. And they've also said that conscience rights must be protected. And the national body has been open and outspoken about this for years now. And the government refuses to even listen to them. So this is a very scary time. I've had, as a result, I've had colleagues of mine who have either reduced their practice or have left the practice of palliative care altogether because of the concerns that we are discussing now. Putting in this, being put in the situation where either they refer someone for euthanasia or they risk suspension or penalization of their practice.
Which is so, I mean, and that's just so detrimental because, I mean, I think what is the statistic? Only 10% of Canadians have access to palliative care. I think it's something like that.
Yes, it's something like that. It's a very small number.
So then you have, if you have physicians leaving, more physicians leaving palliative care, like that's exactly the opposite.
Yeah.
And even the
Right.
government has acknowledged that there is a need for palliative care, that they need to increase their palliative care physicians and all of those kind of things. So that's like, that's really hard.
I just want to share this analogy because I think sometimes people hear this like refusal for, you know, people struggling to make effective referrals. And why would you struggle with that? Because you're not doing it. You're just sending them to somebody else who would, you know. And I want to hear maybe your thoughts on that, Dave. But I used this analogy once because this has also happened on the issue of abortion in various, not just for medical professionals, but even, you know, we've sort of heard of issues about it in campus ministry, like different things like that. And so the analogy that I've used is, you know, imagine you have a person who believes that self-harm, you know, like cutting themselves or something like this is how they can feel better about their situation. And but they have some kind of struggle to do it in this hypothetical, like they can't do it. They don't have the strength to do it, but they really want it done. And they come to you as a person who's part of a team who cares for them in some way, whether it's spiritual, or medically or other way. And they ask you to do it. And you say, no, I will not do, like, I will do, these are all the other things that I'm willing to do for you, but that I won't do. I'm not going to hurt you, you know? And then some kind of weird policy requires you to refer them to someone else who's going to hurt them, essentially. And I think people don't, because people think, you know, it's the patient's request, but people don't realize that the request that's being asked of you is to do something that's going to harm another person. That's where the conscience violation happens. And that in good conscience, you cannot send someone to their harm, you know?
Absolutely. And that's a great point, right? And the core of the argument here is really, you do not believe this is in the best interest of the patient, right? How can you send that person to someone else who doesn't believe the same? Because then I'm doing harm to that individual, right? And, you know, and given, you know, you gave the example of specifically a psychiatric diagnosis of self-harm. There are some rare examples, for example, of someone who wishes that they never had an arm, that they wish their arm is not, these are kind of rare disorders, but where they feel that their arm is not part of them. It's a delusional type of disorder. And that sometimes they will come and they'll ask people to have an amputation. Okay, so obviously, you know, as a physician, I would say, well, I don't believe that's in your best interest, even though that's what you want. I'm going to treat that delusion. Okay, and maybe my treatment doesn't work so well, and the person still asks for that. Would I ever send them to someone who I think, you know, would say, yeah, let's amputate the arm? I would never do that because I don't think that's in their best interest, right? And I think that's ultimately doing harm to that person. Now, a totally different thing from euthanasia, but the point is that if I believe as a physician and I'm convicted as a physician that some proposed treatment is actually going to do harm to the patient, it would never make sense for me to refer to that patient to someone else who thinks the opposite. It just wouldn't make sense.
Yeah.
And that's the same thing that goes for, you know, other things, you know, within medicine.
Maybe as just a last thought before we get into Godwinks, maybe just personally for you, Dave, if you want to share, like, I mean, you have a family, a beautiful wife, hi Robin, and 2 beautiful kids, you know, and so like for you, how does this kind of personally affect you, like thinking about your family, or, you know, supporting them in the future, or even just dealing with people who are like seeking death, or who are without hope, or things like that? Like how has that kind of affected your heart? And is there anything that people can do, like you know, in a general way to support you and other doctors who are kind of going through these things?
Sure, that's a good question. You know, there's some research that has come out of the University of Saskatchewan by Dr. Harvey Chochinov, and it's called dignity therapy. And it's something that's being used in the medical community to help people in the palliative care setting regain a sense of lost dignity, a sense of lost dignity, because people have that sense of lost dignity when maybe their function is impaired because of their illness. Maybe they can't go to the washroom anymore. Maybe they have to wear diapers, right? Maybe they are dependent on others for their basic needs. The memory is now not what it was before. Can't remember basic things, and people have a sense of loss of dignity. And in this research that's come out and now is being used in the palliative care world, we really talk to patients about what really at the heart makes makes them feel dignified, makes their life dignified. Okay, and when we really get down to it, you know, people are talking about so many different things. It's not about the function, right? It's about who they are as a person, what they've done in their life, certainly, but all the wonderful things. There's so many things that people now can rediscover in their life that helps to regain that sense of dignity. Right? You know, maybe they had 2 or 3 children, and you know, they're so you know, being able to raise those 3 children. You know, there's many different things that people forget at the end of life, and part of that dignity therapy is really going deep into those things. Okay, and so, you know, in my experience, and especially working with other Christians and Catholics, you know, I think that a most important aspect of dignity is that being a child of God, and nothing can ever take away that from an individual. And I think, you know, if we can remember that most important and cherish that and always come back to that we're children of God and we share in the Christianhood, you know, that is an amazing thing. And that's something that I always, and I hope I can teach my kids, is to always go back to that sense of dignity in relationship to God, right? Because that's something that will never change. Whether you have an accident and you have a disability, or you go through a suffering or mental illness or whatever it is in life, which we'll all go through, right? But that sense of dignity that is related to God, I think, is the most important thing to teach to foster amongst our friends and even in ourselves, of course, but also in our young ones. And so that's hope, you know, I hope that to teach that to my kids. So I don't know if I answered that question.
Yeah, I think so. I mean, maybe if there's anything that you can think of off the top of your head, like what from the average, you know, Catholic or Christian who's not in the medical field, if there's anything that we can do to support you.
Very practical stuff. I mean, obviously prayer is very important for us physicians, especially the Catholic physicians who are struggling with this issue. There are some wonderful organizations that are really, you know, defending and really tireless at defending conscience rights and our cause. I'll name several. The Canadian Physicians for Life is a fantastic organization, and primarily focuses on medical students, ensuring that medical students know that they have rights as physicians, that there are other physicians that have similar ideas on conscience rights and with maybe pro-life views. And they do a wonderful annual meeting for medical students across the country, and they do many other things as well. So if you can look up their website and if you can donate to them, that would be great. Other organizations are, well, Garnett Genuis, you know, following him, and people like him on the political side is very important, and they're really working tirelessly to put our cause in Parliament. Going to your MP, of course, is very important, and letting them know your concerns. The Catholic Physician Society is also, for those Catholics out there, Catholic Physician Society is a national body, and we have smaller chapters at all the different major cities. And we've been working with the Christians, the CMDS, Christian Medical and Dental Society, also a wonderful group of Christians across Canada in the medical and dental field. We're working together with them on this cause, and we've been doing that for a long time now. So those two groups, prayers for them, and if you feel called for financial donations, that would be greatly welcomed as well.
Yeah, and I think just even throwing back to what you're saying, Dave, earlier about the importance of community. So I'm thinking about my almost 92-year-old grandmother who lives in Montreal, and she's in kind of a seniors apartment complex, and she a few months ago, I guess she had all of them were kind of isolated with COVID, obviously, in the situation there, and she had, I guess, a friend down the hall who called her one day and was just saying, I'm just so lonely and I can't see my kids, and no one's calling me, and I'm lonely and I just want to die. Like, I just need to die, kind of thing. And so my grandmother, who's she just was like, okay, well, how about this? I'm going to call you every day, and we're going to pray together. We're going to pray for our kids. And I don't think this person, the other woman, was a person of faith or anything like that. But my grandma was like, I'm going to call you every day, and we're going to do this thing. And they started doing that. And I guess this just brought this so much life. And they started to each other, and they would sometimes go and sort of meet in the hallway 6 feet apart and things like that, And so it's a thing of, okay, if a 92-year-old can go and bring life and hope to someone else, like, who are the people who are in our lives? Maybe you've got that great aunt who is in long-term care, or I need to do better at this, of just even calling my grandparents more often, and just, maintaining that relationship and showing the people who are maybe ill or sick or whatever it is, just the gift of time. And it doesn't have to be crazy, right? Like, just call once in a while, it can make a big difference. So just these little things, because it's, I think it's so important to work to, in the political sphere, to change laws and protect conscience rights and all of these things. But that's always difficult, and who knows what we're going to be able to do. And we want to be hopeful, but it's hard to know what change is going to actually happen in that sphere. But we can 100% always change the culture with our actions, right? And build up this culture of community and support and life and dignity, right, for people. So just thinking about what are the small things we can do, both in the like Dave was saying, like, even financially supporting, like, anything in this political sphere, but also, like, in community. So
Oh, 100%. I love that. Just spending time with people affirms their dignity, and sometimes that's the only thing we need to do.
Yep,
exactly. Yeah,
totally.
Yeah, it's true. Wow, that was a really rich discussion. Lots of stuff. Thank you so much for joining us. And we're gonna take the last few minutes here to share our God winks. So I'm gonna pick on Nicole first. Nicole?
Oh, sure. Well, my God wink this week is I was thinking about this. There was a conversation or a topic that I wanted to bring up with somebody, but it was one of those things, and I just sometimes struggle to know how to bring things up, and I was like, I don't know how to talk about this. I don't know when or how, and I was just like, it's impossible. So I was like, well, I'll just pray that God will do something, so I don't have to like, he'll just fix it, so I don't have to talk about this thing, But this week I was having a conversation, and all of a sudden it was like we were talking about this topic that I needed to talk about. It's like it just kind of happened, and I felt like it was like the Lord just being, I don't know, it was just a grace to have that topic come up, and then we talked about it, and I was just kind of shocked, because I was not planning on doing that, because I was too afraid. So just grateful for, I guess, I don't know, the Holy Spirit sneakily leading in that way.
That's awesome.
Yeah.
Sweet. How about you, Rachel?
Yeah, I think my God wink this week will be actually a bit vague. I'm going to go with a vague one, because it's just been a week of a lot of learning for me about who I am, and like the Lord just bringing lots of conversations into my life that kind of on the opposite end maybe of Nicole, instead of like me wanting to have a conversation that was hard, I just have been having a lot of conversations I never expected to have with lots of different people, friends I haven't connected with in a long time, my family, just lots of different people. And all of them have been very illuminative, you know? So I just have felt like there's been a lot of light kind of shed in to my life and things that God is calling me to work on. So yes, it's a bit vague because a lot of it's very personal, but it's just
Okay,
been so
mine was
cool.
vague too. It's the theme for the week, I guess.
I have a very specific one this week, so that's okay.
perfect.
It balances out. How about you, Dave? Do you have a God wink?
Well, that's actually I never thought about it until now when you asked. But I think my God wink is actually connected to the topic. I've been feeling. I kind of mentioned this before to you guys, and I've been feeling very down about what's happening in this area. A lot of my colleagues are feeling down about what's happening, and we feel not heard, and we feel that people don't care about it, and this is why things are moving forward the way they are. And my God wink is that I got your message, Erin, and that you girls have the the courage to talk about this and to reach out to people, even when through the people are so focused on COVID, and you're organizing this and letting people know that we still care about this, we still want to move things in the right direction. It really lets me know that we are heard. It lets me know that we have other people affirming us. And for me, that's really a God moment. And thank you, girls, for that.
That's beautiful. I love that. Mine sounds crazy after that. It's such a beautiful one. Mine has to do with Michael's craft store.
Nice.
Because so a couple of times a year, a few times a year, whatever, whenever they change seasons, they have these grab bags. So basically they'll just put out something on social media and be like, oh, hey, tomorrow's grab bag day or whatever. And then you go in and they have these massive like bags of just I don't know, craft stuff or like whatever. And you can buy up to a cart full, depending on the store. Like one woman went and bought 40 bags of them from one Michael's. Yeah. And they're $5 a bag. So my dad and I went to the one here in Canada and got 10 bags between the two of us of this craft stuff. And it's like, it's like hundreds of dollars worth of stuff per bag. Yeah.
That's
and
still
it's
happening?
all, yeah.
Can I do that?
No, it's all done now. but it's like right now it's all like Christmas stuff, so whatever.
Right.
My sister will use it for crafts for next year and da-da-da. But there were a few things that were not Christmas things. So one was this beautiful watercolor kit. Actually, it's like a beginner kit. I can even show you here with all kinds of watercolor paints and watercolor pencils and and normally this kit is, I think, $40 or something like that, and it was included in a bag with all kinds of other stuff. So
For
it basically
$5.
cost nothing. Yeah. So I kept it for myself. That didn't go to my sister. But
Aw.
I've been wanting to try, because I've been doing some acrylic painting. I wanted to try watercolor, but it's like, oh, I don't want to pay for all of that. What if I don't like painting with watercolor? And then the Lord was like, here you go.
Oh,
surprise.
So, yeah.
Aw.
So that was fun.
That's cool.
Yeah.
That's beautiful.
So very concrete. Yeah.
I love it.
Well, thank you so much.
Can I add one thing before we close our episode? Just again, we did this at the end of our last episode with Garnett as well, but just to encourage everybody right now, we're having this conversation because it's really important. It's also really topical. So all the things that Nicole mentioned, but also all the things that David mentioned, please, if you feel motivated at all, find some place that you can act and you can do something. And especially if you have 10 minutes to write a letter to your MP about conscience rights, about Bill C7, or just sign the NoSameDayDeath.com petition. I just want to give that extra little push right now, because right now it matters in a really big way. And so each episode, I think we're going to just encourage you, no guilt tripping or anything, but as Catholics, this is a time that injustice is literally happening, and we have the opportunity to speak up. Whether or not our voice will make a difference is in the Lord's hands, but we have that responsibility to actually use our voice. So please do.
Even for those who are, like, we have some listeners from the States and other areas of the world. And in many of those areas of the world, there's pushes for, or euthanasia is already legalized there. So, if you're not in Canada, like, look what's happening in your area and write somebody or call somebody, and please pray for us. Please pray for Canada right now. Please pray for us.
Yeah.
So, well, thank everybody ahead of time for for doing that. But yeah, Dave, just a big thank you for joining us this week. It's been like such a gift to hear, and thanks for everything that you're doing and that you have done, you know.
Yeah.
Well, thank you girls so much. You know, I'm sure so many listeners that listen to you every week. Is it every week you have your podcast?
Millions.
Millions, yes. It's gonna grow, I'm sure.
That's right.
So
with a topic like suffering, you know, it's just...
exactly. Immediately marketable. Yeah.
Actually, thank you to everybody out there who does listen to us.
Exactly.
Please feel
We
free
really
to
do
share
love
this
you.
conversation. This is such an important conversation. So
yeah, that's right.
Share it with everyone that you know.
Amen. All right, guys. Well, we'll see you next week, huh?
Yeah, sounds good. Thank you, Dave.
Good
Bye,
to see you.
guys.
Thanks for having me. Bye.
Thank you for joining us for this episode of In the Thicket. If you like what you hear, give us a rating and hit that subscribe button. We have new episodes every Monday with more stories and honest conversations about life when the going gets rough and the hope and humor amidst it all. We'd love for you to join our community on Instagram and Facebook at In the Thicket Podcast. While you're there, let us know how we can pray for you. God bless and see you next week.